Welcome to another session of Pioneers in Interventional Cardiology. Our topic tonight is carotid stenting. And I'm Dave Cox from the Sanger Heart and Vascular Institute in Charlotte, North Carolina. And I'm really honored and delighted to have Chris White from the Ochsner Clinical School of Medicine and Gary Roubin, now working out of Jackson Hole, as our two pioneers in interventional cardiology that we're going to have a wonderful discussion about. I was one of Gary's interventional fellows at UAB, where he taught me everything I know about interventional cardiology. And Chris has been a beacon of reason in our field for years, who coached many of us to follow him as a great SCAI president. So without further ado, Chris and Gary, can we begin with tell us how the field of carotid stenting began?
Chris, I think we agreed last week that you may have put the stent in a few weeks before we did at UAB. So why don't you begin by telling us how you got started, and then I'll give a little treatise about how we got started at the University of Alabama.
Well, I think, thank you, Gary. I think that it was simply the way that interventional cardiology evolved from the earliest in the 80s, and that was there was a need. There was a clinical need to address patient concerns that were unattractive for the conventional surgical options. And so we had a very early heart team, although it was neurologists and interventional cardiologists who would meet together and discuss treatment options for patients, best medical therapy, surgery, or possibly this new thing, stenting, which Steve Ramey and Ty Collins, my partners in crime, we were all in this together. And we felt like we could access the carotids. We felt like we had tools that could address this disease. And originally we used iliac self-expanding stents. And we were talking to Gary and we were talking to others around the country all the time. We met at meetings. It seemed in those days they were every other month somewhere, always talking about what moved the field forward. And we would learn from each other well before anything could be published or learn from randomized controlled trials. But again, without the support of our neurology colleagues who saw the need for this less invasive therapy, we would never have gotten started. And then I think back in the early 90s, interventional cardiologists were pretty courageous. I mean, we were used to doing coronary stents with balloons only. Carotid seemed like a pretty big target and pretty amenable to our therapy. Gary?
Yeah, thanks, Chris. Well, I was fortunate at UAB to be able to collaborate with a neurosurgeon, and I want to mention his name, the wonderful late George Vitek, a wonderful colleague throughout my year, and then someone we've all got to know over the decades, Jay Yadav, who was a board-certified neurologist, who actually came to me and said, look, are you guys doing such a good job with myocardial infarction that I want to learn how to do this and go up into the brain. And I said, well, hang on, Jay, first you got to train. I mean, we've been doing this for decades using catheters and wires. And he agreed to come and join us as interventional cardiology fellow as a board certified neurologist. We had a multidisciplinary team. Now, of course, before your work and my work, there was anecdotal stuff going on. Jerry Vitek had done some balloon angioplasty of the carotids and reported it, and I have a copy of one of his earliest case reports. In Europe, Jacques Theron, Chris Villeneuve, and Klaus Matthias had also dabbled. There was even a guy back, a Russian guy, who in 1979, his name was Roubin, put a nitinol stent in a carotid artery. So there had been anecdotal reports. What we did at the University of Alabama was to try and insert some good clinical science into this potential interventional procedure. So we wrote a protocol, a very rigorous protocol, got IRB approval, informed consent documents, got the protocol approved, We had a multidisciplinary team, including the neurosurgeons, the vascular surgeons that refused to participate with us. And so we began this study with this formal protocol where we had rigorous neurological examination by board-certified neurologists of every case. And that was important, and we can talk more about how that became even more important. We had follow-up imaging, so that's how we started. Our first 5 cases were just balloon angioplasty of the carotid bifurcation. Now let's remember, this is March 1994. The coronary stent, the Roubin, first FDA-approved coronary stent, was not even available. We had it at UAB, and I think you might have had it down at Ochsner, a few other of the investigations.
We had the Victor.
Exactly.
We had the Victor, yeah.
So we started just ballooning these cases. We got to number 5. We had a bad outcome. There was the lesion, very severe, 90% lesion, and a very sick elderly patient collapsed, bad outcome. We stopped our trial. We sat down. We tried to figure out what the self-correction would be. And self-correction in clinical science is always very important. And we decided then that the stents we'd been using now since 1987, so this is 1994, and we still didn't have an FDA-approved stent till the GR stent was approved. And we decided we were going to put stents in. And as you pointed out, Chris, the stent that was available was a balloon expandable Palmaz iliac stent. And so we went back to the IRB. We said, we think we've got a solution. And we started prospective implantation of a Palmaz stent. And just to give you a sense of the self-correction and evolution, we did about 50 cases with pretty good outcomes. And then we were bringing the patients back, and we saw that these balloon expandable Palmaz stents had in fact collapsed under not all of them, but enough to concern us with the superficial pressure of the neck. So then we turned to self-expanding stents, and the only self-expanding stent available at the time was a tracheobronchial wall stent. So we began using the wall stent. Now, of course, there was no sense of how we could provide neuroprotection with filters, but that's essentially how it started. And again, great support from our neurology colleagues and neurosurgeons, and just total antipathy and the beginning of the war that we had for the next 30 years with vascular surgery.
I just want to add to that, you know, we were often characterized, or at least the vascular surgeons often thought that interventional cardiologists were cowboys, and we were just looking for things to do. And nothing could be the farthest from the truth. We were initially carefully selecting patients with our neurologists for people who were just not candidates for surgery, people who had had anatomic or physiologic reasons why carotid endarterectomy was a really bad option for them, and they were at very high risk for stroke, again, driven by the non-invasive neurologist saying something needs to be done. They can't have the conventional therapy. And we had migrated to the self-expanding stents very early on as well. And we got excellent results. And the same as Gary, all our patients had neurology follow-up and neurology examination. I think the discipline of interventional cardiology, the science that I guess goes all the way back to the Emory days, when everything done in the coronaries was carefully documented, measured, recorded. We learned, that's how we learn, is by careful. We weren't just doing clinical work and wondering how it was going. I mean, we were all working from protocols. We all would review our data. We all collected that data. And as Gary said, course corrected when we needed to.
It's interesting, Chris, as we reflect back, because it was very clear, even in the early 90s, that coronary stenting, the coronary stenting was really going to make Andreas Grunzig's balloon procedure something that would allow us to get into multivessel disease, and we're going to really knock the cardiac surgeons back. But this we did, of course, Barry trial and all these other studies that we've done since. But then I had, after having the cardiac surgeons on my back for about a decade, now I was affronted by the vascular surgeons who were much more vitriolic, because they really felt that this lesion in the neck was their territory and no one else had a right to do anything with these lesions in the neck. And I'll just point out one thing that happened to me, because like you and David, patient care was always the most important thing to me. I remember seeing in a waiting room at the hospital, at University Hospital in Birmingham, Alabama, a woman waiting to be seen. She had this god-awful 6-inch scar down the side of the neck. The neck was swollen, clearly had a big hematoma. Some of the wound was infected. She was sitting there and looked absolutely miserable. And if we think back to all we've done in interventional cardiology to offer our patients less invasive, non-surgical options for the maladies, the vascular maladies that they had, it seemed to me that if we could do this percutaneously, and now it's even an outpatient procedure, it's a 20-minute procedure. If we could do that, and if we could prove we could do it safely, and if we could prove that it would prevent strokes, that this was a much, much better option. Now, of course, the surgeons are not happy about my characterizing endarterectomy that way, but it's a reality. And we can, as we go through this discussion and move it forward 30 years, I believe I was correct in assuming we
Well, I can tell you, Dr. Ramey, Dr. Collins, and I were on more than one occasion brought before our ethical board, accused by the surgeons of malfeasance, and we couldn't have defended ourselves had our neurology colleagues not stood up and said to the surgeons, "Listen, guys, these are our patients, and we will decide what's best for them. Some will get surgery, some need stents, and some will get medical therapy." And at the time those things happened, the non-specialist judging us had to defer to the neurologists as the experts in the field. And had it not been for our neurology colleagues, I think the field would have been set back tremendously. So they deserve a lot of credit for support.
An interesting experience at the time, David, and you were there, and you will remember this, that we had got maybe 100 or so patients stented with carotid stenting. And all of a sudden, we were made aware that one of the vascular surgical fellows, without asking us, without any IRB approval, without acknowledging what we were doing, had gone into the medical records and gone through all our medical records and then, quote unquote, case controlled 100 vascular endarterectomy cases. Well, this was ethically and morally an extraordinarily unsavory thing to have done anyway. But of course, he wrote it up and got it immediately published in the Journal of Vascular Surgery. And this began this belief amongst the surgeons that they were the only ones who could do this safely and effectively. So what happened, interestingly, and Chris will acknowledge this, we carefully, our neurologists carefully examined our patients. So we would call a stroke anything that involved even drift with the arms, or optical field defect, or anything at all was called a minor stroke if it didn't go away within 24 hours. The surgeons, of course, in their clinics, they didn't even see their patients when they sent them home. And I once brought this up at one of the many, many decades of debates. And the vascular surgeons stood up and pompously told me that you telling us we don't know when our patients have a stroke, when the patient drags himself out of the hospital, dragging his arm and his leg, he's had a stroke. So that's what we were up against. And but I think we persevered, and I think it's probably time to get Chris to expand on how we figured out how we could self-correct and how we could make this procedure into what we have today, which is an extraordinarily safe, efficacious way to prevent strokes in both symptomatic and asymptomatic patients.
How do we get there, Chris? I mean, I'm intrigued about the IRB, getting hauled up in front, and your credit to the neurologist. So here we've got a group of experts that are using devices successfully, and you're collecting data. What was the next step to make this work?
So in the early 2000s, maybe late 90s, but early 2000s for sure, there was a rapid evolution of development of technology. Again, we started with devices that were not purpose-built for the carotids. The manufacturers soon saw the opportunity for less invasive therapy for stroke prevention. And so multiple vendors developed tools. Gary mentioned earlier the embolic protection devices, just purpose-built equipment that allowed us to much more safely approach these lesions. And so that was a huge move forward. And the discipline that we had learned in coronary work to do trials. I mean, carotid stenting is the most studied medical procedure of all time. I think that we count those trials. No other medical device has had that therapy. Part of it is because of the reimbursement challenges. We kept trying to have to go back and prove and look at the subsets of patients. But just tons and tons of work and leading up to, the modern day CREST-2, which is another very disciplined trial.
So when you did these trials, did you limit your investigators? I'm trying to think of TAVR. If the first TAVR trial had a bunch of rogue investigators, we might not have had the results that convinced everybody. So how did you guys limit it?
I will say that SCAI deserves quite a bit of credit. SCAI was, back in the early 2000s, struggling for an identity. Who were they? How did they separate themselves from the ACC? The ACC was the big monster. Everybody was a member of the ACC. What would motivate people to embrace an interventional society? And SCAI really got into the coursework. And really, we trained a generation of interventionalists interested in carotid stenting. Gary was involved in a ton of those courses. And it really showed value to being a SCAI member, because SCAI was there for you. SCAI made your practice better, more valuable. And we limited, if you look back at CREST, roll-ins were very common. We wanted to make sure people were competent to do the procedure before they actually counted. So that was one of the protective mechanisms that we had. For CREST, the original CREST trial, the roll-ins were really quite interesting. There were neurologists, there were radiologists, neurosurgeons, and vascular surgeons. And the only people who underperformed in the roll-in procedures were the vascular surgeons. They were pretty clumsy with their hands.
Yeah, there was no question. It's interesting you bring that up, Chris. There was no question that the interventional cardiologists doing this fine work in the coronaries, and then, of course, Chris and I were instrumental in moving the cardiologists throughout the vascular system into peripheral vascular work, renal work, brachiocephalic work, and the cardiologists were those that were the most facile at accessing the carotid artery safely. And so about 60% of the investigators in CREST were interventional cardiologists, and then a smattering of vascular surgeons interventional neuroradiologists, radiologists, and ultimately, as it evolved, interventional neurologists as well, and neurosurgeons who all jumped in. But interventional cardiologists have really were responsible for this. And this day and age now, it's as we've moved up into the brain itself, things have spread out. It surprises me that more interventional cardiologists have not got themselves up to scratch and retrained. And I think you've mentioned SCAI, Chris, and I think it's very important that we get back to serious teaching courses at SCAI. And the reason is that for interventional cardiologists, we're cardiologists. Approximately 50% of our patients have carotid disease. Stroke is a big issue for these patients. We diagnose it, we see it, we have to manage it, and we are more than capable of doing this percutaneously in a minimally invasive way. So even in CREST-2, the majority of the accredited operators, not quite as many as in CREST-1, are interventional cardiologists. And so the interventional cardiology discipline should take great pride in what we've accomplished. As Chris mentioned, not simply that we develop these techniques and we develop the technology. Give Jay Yadav credit coming out with the Cordis self-expanding stent and his filter device, which was really Sri Iyer's idea. I've got to give Sri credit. And then we came out with the NAV6 and the exact stent. And but the interventional cardiologists really grabbed this and ran with it. And I would say, and you saw it, Dave, and over the next 30 years of doing this, it's one of the most gratifying interventional procedures. If you select your patients carefully, you pretty much use the same equipment on every case. And we can talk about how the stents have even got far better and our peri-procedural results have dramatically improved. But it's a very predictable case. You can line up 5 carotids and be out of there by 3 p.m. Whereas you never know what you're going to hit with a coronary case, as we all know. So it is a gratifying procedure, and patients really don't want to live with a high-grade stenosis, whether it's symptomatic or asymptomatic, and risk ending up paralyzed in bed, aphasic, or even worse. So it's a procedure that I think belongs really firmly within our sphere of interventional strategies.
I mean, it's a bimodal curve, Dave. There was the enthusiasm for approval of the devices and getting them there in the early to mid 2000s. But then we had the non-coverage decision happen from CMS, which was extremely political in nature, in which basically reimbursement for carotid stents was denied for anybody not in a clinical trial, which also drove the number of clinical trials we did, and also for people who weren't at high surgical risk. And at one point, there was even a rule that said a surgeon had to write a note in the chart if you wanted to get reimbursed by Medicare, which was really a problematic issue. So that 2006 non-coverage decision with Gary and a group of multidisciplinary people, we got changed 2 years ago. And so finally, carotid stenting is now on equal footing with surgical revascularization for reimbursement. But we've lost significant time in training. And so we do need to go back. There is a role for SCAI to coordinate resources and to rebuild the training workforce for carotid stenting.
Yeah, I'm thinking of 2 people, Chris Metzger and Bill Gray, who sort of you guys brought along. And I think that non-coverage decision really did hamper institutions and sites getting going. So we're at kind of a new curve in the road, if you will.
Yes.
Right.
And then, of course, we have to talk about the carotid cut down for TCAR,
TCAR, yeah.
which is now more than 10 years old. It's actually 12 years old since it was first reported. And we don't have to look too far to find the randomized controlled trials that demonstrate the benefit of TCAR because they don't exist, right? They simply are non-comparative case series run by the surgeons who are not as data careful as we were. And so now you have reimbursement for TCAR with much less scientific assurance that it's as good or better than any general surgery or carotid stenting. But we have much fewer fights about it now because the surgeons have their option for carotid stenting, and we have our options, and so that's fine.
What got the decision 2 years ago to change in terms of reimbursement? What did you two do?
Actually, we have to give Kenny Rosenfeld some credit here. Kenny had a running dialogue with many or several of the CMS individuals who, frankly, were reading the literature and you have the CREST-2 trial, which the NHLBI basically says there's equipoise between stenting and surgery, right? They start off CREST-2 not saying we're going to compare them. We're saying they're equal. Choose which one you want and use best medical therapy. So once the NHLBI and NIH had acknowledged the equipoise for the procedure, CMS was pretty embarrassed with that NCD. And so we simply helped them with gathering the data that they needed to see that could allow them to do the comparative analysis they needed. And it was actually, I think, a pretty easy step for them.
It was a war that went on for 25 years. We lost many battles, but we won the war. We won the war because we did the work. We didn't stop. We did trial after trial. We did CREST trial. 2010, NHLBI declare we have equivalent procedures based on the pre-specified endpoint. Now, there were significantly more MIs with endarterectomy, and there were more minor non-disabling strokes with carotid stenting. Major strokes, death, and the prevention of strokes we wrote in a 10-year follow-up, were absolutely equivalent. But the vascular surgeons had their cabal in Washington, D.C., and they beat us back, and they beat us back. In 2023, Kenny, myself, Chris, Nick Hopkins, vascular surgeons who've been doing stenting, neurologists, interventional.
Yeah, Sean Layden was there.
Sean, I was missing Sean. Right. We got together. We got some attorneys who were going to help us, and the attorneys, we had multiple Zoom calls. The attorneys said, "Well, give us something to work with." And I sat down and wrote a 26-page document. I pulled every bit of literature together. I sent it out, and Chris turned it into a wonderful publication. And we gave that to the lawyers. And the lawyer said, "Oh, my goodness, now you've given us what we need." And they took that formally through legal pathways to CMS. And we won that. We got CMS approval. Chris is right that by this time, the surgeons who had been beating me up and Chris on the podium for 25 years, that stenting was worthless, it was dangerous, and it didn't prevent strokes. They finally discovered they could do stenting if they did a cut down on the neck. And all of a sudden, stenting was the best thing since.
Well, because the patients weren't walking out of their offices saying, "I don't want surgery," right?
Right.
They had something to offer.
Two other interesting elements, in addition to the fact that they have never subjected TCAR to any rigorous level 1 science. Unlike broad stenting, as Chris mentioned earlier, which has been through multiple trials, and we've established its bona fides. The surgeons have not done that. But more importantly, I looked at the CREST results. I was on the CREST executive, and I wanted to include cranial nerve injuries, and all the surgeons in the committee said, hang on, cranial nerve injuries are not, they're not even minor, they're not as bad as minor strokes, you know, and we're not including those. If we had included those, stenting would have been superior to endarterectomy in 2010. Fast forward 15 years, the surgeons are now not opening up the neck. They're using a little incision. They're placing a stent. Guess what? I heard a little debate a week ago between two vascular surgeons, and the one that was talking about TCAR, promoting TCAR, said, and by the way, we don't get any cranial nerve palsies when we do it this way. And this is really important. So maybe what goes around comes around. But I would also note that the surgeons feel that they have invented flow reversal with their TCAR procedure, and percutaneous stenting, you don't use flow reversal, you use filters. Wrong. We've been using flow reversal percutaneously with originally the Carotid device and the Momo device for at least 10 years in high-risk lesions. And back in, I guess, about 2005, you remember, Chris, we had the PercuSurge device that we'd put up. We'd occlude the distal carotid, and we'd bring out all that blood. We had absolute flow reversal. The surgeons think they invented flow reversal. We interventional cardiologists invented it decades before they thought of it. So we should give the lie to that position on their part as well. Perhaps we should turn.
I wrote an editorial once called Liar, Liar, Pants on Fire.
I think you did.
It might have had something to do with that.
Perhaps we should turn to the state of the nation now and talk more about this really advanced technology and techniques. Perhaps something you were a big part of, Chris, and also Nick Hopkins. I want to acknowledge Nick Hopkins, a neurosurgeon who, from the very beginning, he said these interventional cardiologists are right about this, and he was on our side of the trenches the whole time.
And Mark Woolley?
Mark Woolley, Alex Berenstein, a wonderful interventional neuroradiologist. So we had our supporters, and I want to very much acknowledge them. And again, acknowledge Sri Iyer's contributions to this and Jerry Vitek. Jerry Vitek single-handedly taught hundreds of interventional cardiologists how to use neuroradiology catheters to very safely access the carotid arteries without embolizing. So one of the other arguments for TCAR is they don't have to mess with the aortic arch. Well, we figured this out a long time ago with technical expertise to very carefully use the neuroradiology catheters and access the aortic arch. And so we rarely saw any events associated with anything but dilatation, treatment of the lesion.
You're absolutely correct. The technical expertise is imperative to negotiate and engage carotid arteries. You can't simply bull your way up the aortic arch, flip a catheter around, spin it 3 times, and hope it lands in the right spot. So that technical expertise is important. The other major advance in the last 3 or 4 years was the acknowledgement that a pre-procedural CTA of the aortic arch could go a long way to helping you understand at least who is high risk or who might not benefit. And we were not routinely imaging arches back in the day, so we never quite knew what we were going to get when we got there. I think having a CTA in hand now goes a long way to either excluding some patients who are extremely high risk, or at least preparing you for maybe a radial approach or an alternative approach in someone else who looks at high risk. So I think the field really took a leap forward with that information.
Absolutely correct, Chris. And it really leads us into talking about patient selection, because what we learned and then we taught and we practiced
I do think that if I was teaching current fellows about carotid stenting, I would start with patient selection. That is the most critical step, because if you can identify those at highest risk, we do what you just suggested. We find alternative therapies, and then we can focus on the people that we can help the most and hurt the least.
Chris, you know that if you select those patients carefully, and again, it's about 80% of the people you're going to see, that it is about 10 minutes or 6 minutes, filter up, filter down. The entire time in the cath lab is about 40 minutes. The fluoro time is 10 minutes max. It's the most reliable, gratifying procedure you can do. So
the alternative to that, Gary, is when you find yourself with prolonged fluoro times and prolonged procedure times, you're in trouble, right?
That you go back and you say, my mistake, I selected the wrong patient. Tortuosity, calcification, that's pretty much it.
I'll never forget when Dick Schatz was at TCT doing the first Paul Schatz coronary stent. And I'm sure you were in the room, there were 50 of us gathered around watching Dick do this, and he could not properly engage the left coronary. And everybody in the audience thought they could engage that left coronary artery. But Dick was uncertain. He didn't like it. And he actually backed down. And it was one of the most courageous interventional things I've ever seen, because he had so much pressure to demonstrate that device. And he just was not going to do something that he didn't feel appropriate. And I think that kind of courage runs through many interventional cardiologists, to be able to say, no, not now. I'll explain to you why later, but we're just going to stop for now. This is not good.
Yeah, I think that's a key point. You two invented a field, and we're not cowboys. We're not crazy, wild guys trying to end up doing something. Can you help our audience just reiterate again CREST 1 and then launch into CREST 2? I know you can't share everything, but I'm just curious if you could just help the audience understand the importance of CREST 2.
Let me just get back to CREST 1. And so over the 12, 14 rigorous prospective trials, including randomized trials we've done, we've brought the Peri-procedural stroke and death rate down from what was about 5%, sometimes 7%, sometimes 4%. The last two FDA trials we've done, it's hovering at 2%, 1% now, soon to be published, already being presented. For asymptomatic patients, less than 0.5%. This is important because as we move into CREST-2, it's all going to be about, can we beat medical therapy? And if you have peri-procedural strokes, it's hard to beat benign medical therapy. But when we were doing CREST and we saw these minor strokes, we had to figure out how to beat this problem. And we beat the problem through new technologies. And these last couple of trials, the performance trial with the double filter, stent on a balloon, and then the C-Guardians trial, where we have the micro mesh with extremely tiny pore size on the outside of the nitinol stent, which captures all the plaque. We've seen these really outstanding results that have transformed what we can do as interventionalists in treating carotid disease. The surgeons will soon have access to these micromesh stents in their TCAR procedures as well.
So I will say that is absolutely true. And CREST set the stage for fine-tuning, optimizing the treatment of those patients. We then come through the randomized trials looking at endarterectomy and stenting for asymptomatic patients, which make up 75% of the patients we treat. The large majority of candidates for revascularization are asymptomatic patients. And we demonstrate, again, equipoise for the stent versus endarterectomy. But what we haven't done and hadn't done, and there were many vocal advocates for medical therapy for asymptomatic carotid stenosis, believing that the natural history of asymptomatic patients on guideline-directed medical therapy being a stroke rate of less than 1% per year. That's recently been challenged. There's evidence now that there is a stenosis sensitivity greater than 80%. That event rate may be significantly higher than that. It's been rejuvenated. But the purpose of the CREST-2 trial was not to compare stenting to surgery. We've already agreed there's equipoise. It is to compare stenting to medical therapy. And as Gary said, the Achilles heel of any procedure is that you absorb your complications up front. And then over the run rate of the follow-up, you hopefully catch up with the natural history of that disease. So the more you can minimize these complications, as Gary has said, if you can have peri-procedural stroke and death of less than 1%, you then become competitive and perhaps superior to the natural history of the disease over 3, 4, 5 years, because we just don't have 20 years in order to prove. It's like the bypass graft story, right? Bypass grafts all run out of steam at 10 years. Nobody's ever suggested that we run a study for 15 to show that they all fail and stenting works better, right? So we just don't, we don't have enough time to prove what we know is true. We have to do better up front so that we can show that interventions are better than medical therapy.
When will CREST-2 results be available?
The CREST-2 results will be presented with a simultaneous publication in the New England Journal of Medicine at the Interventional Neurology meeting and the VEITH meeting in New York, second week of November, or third week. And we'll have the results of 4-year outcomes. And that's just the beginning. Because there's so much to look at within this 2,500 patients randomized. 2 parallel trials, one half were randomized against stenting, one half were randomized against endarterectomy, each with a concordant medical arm. The medical treatment for these patients has been, it cannot be said loud enough, 5-star. I mean, they were called for smoking cessation diet, their hemoglobin A1Cs and their blood pressures and their LDL cholesterols were monitored and they were corrected. So this represents really the best medical therapy any patient will get. However, I happen to know that the compliance rate was very good in terms of medical therapy, but like all medical therapy, it's 70%, 80%, maybe 60% compliance rates. Plus, there are all the issues of complications of medication, costs of medication, the issue of patients sitting on a 90% stenosis. I know I randomized a lot of patients in CREST-2. I randomized a lot of patients in CREST-1. Patients I otherwise could have treated, but I believe in this level 1 science. We learn so much. So what the CREST-2 trial will tell us, using first generation technology. Let me say that again. The technology, now medical therapies, well, let me deal with the technology. The technology is absolutely improved. And so what we do today with a 0.5% peri-procedural risk using the latest available stent technology is different. We'll see. I don't know what the outcomes were, peri-procedural outcomes were in CREST-2, but probably not going to be a 0.5% because it was first generation technology. So that's the first thing. Now, we will know what happens when you treat the medical patients. Now we can do provide personalized advice to our patients saying, do you want a one and done procedure where you're not worried about having a stroke from your 80% blockage, or with the risk maybe 2, 3, 4% a year? We don't know. We will do that analysis in CREST-2. And do you want to potentially, and we're also studying this in CREST-2, to have increased risk of dementia with a high-grade blockage? Well, that may be an issue. Or do you want a one and done procedure in 2 or 3 weeks or next week with a 0.5% risk? That's why CREST-2 is going to be very important. Now, of course, with GLP-1s and injectable LDL lowering agents, the neurologists will argue, well, medical therapy's got better too. So we'll start again. We'll do another 10-year trial.
I don't think we could talk about CREST-1 and 2 without mentioning the leadership of Tom Broad, a neurologist. Tom is visionary. He actually believes in carotid stenting, but has been extremely diligent in pushing this field forward, engaging all of us. He's got friends on all sides of the question, and he's just been a real giant in the field.
So let me finish up and just ask, what's the future? If you're a young interventionalist trying to finish up your fellowship or just come out, what's the future for carotid stenting in 2025?
So the future, I think, and I'll let Gary finish, but I think, and I tell this to my fellows, the future is very bright in non-coronary interventions. And to stay the heck away from TAVR and structural. There are not enough cases to keep people busy. And all you're doing is being a caddy for the staff guy and then try to find yourself a job. Whereas someone who's skilled in peripheral work, in renal artery stenting, in carotid artery stenting, there's a lot of opportunity to help patients and a lot of ways to stay busy. So if you're smart, that's the direction to go.
Well said. Gary?
I would add that the best trained, and I've got a lot of my fellows who are now top shelf structural heart guys, like, Nicky Van Meegen and David Wood and others, but they were all trained to know how to handle anything that goes wrong in the iliac arteries when you're accessing. They also know how to very quickly access the carotids for neuroprotection during TAVR or these other structural procedures. Or I do believe eventually we're going to figure out that even if you're preventing the occasional stroke, it's so easy if you're facile with carotid access. I think that even if you were headed into the structural space, which TAVR now has become just a very bread and butter procedure, to be able to very efficiently, be competent. That's a great word. My good friend Piotr Musialik in Poland, he talks about there's carotid stenting and then there is competent carotid stenting. Well, we think we train our fellows to be competent coronary operators. They should be competent peripheral operators, at least in the SFA and iliac vessels and renals and brachiocephalic, and I believe up to the carotid bifurcation. So I would urge anyone who wants to be top shelf interventional cardiologist, you take the time to learn your peripheral skills, learn your carotid skills. You will be a very effective, well-rounded interventionalist. Even in the structural field, you will not need to be sending a message out, can you find the surgeon? Can you find the vascular surgeon? You don't need these guys because you can do it all. I think that's a really important message.
Well said. Well, I just want to thank both of you. I'm going to let you two have the last word. I know it's been a tremendous accomplishment in what you've done for our field, not only in carotids, but in other areas. Chris, we'll start with you. What's your last words and comments, and we'll finish with Gary.
I will just say there's really no I in team without my partner, Steve Ramey, Ty Collins. Close relationship with Gary, Shri, others we've mentioned on this call. We would never have been able to do what we do. It is done. It is a family. It's the beauty of interventional cardiology. We grew up together doing this. I worry that my youngsters that we're training now don't have that family. They don't have the same cohesiveness that we all had. And it's been the best part of the career, best part of the job.
Well,
thank you, Gary.
Gary?
I think there are a couple of things to be learned from our carotid experience, and that is, first, you need to do the work. We got what we've accomplished from just being relentless and working hard. 7 a.m., 7 p.m. last case, and then 2 hours talking to a patient. So they're in the Act 1 trial, or in the CREST trial, or in the CREST 2 trial, or another trial. You know it, Dave. I've seen you doing it. It's work. The other element is that the clinicians that push the science forward are always the busy clinicians. When you do a lot of cases and do that work, then you know the way these trials need to be structured, the way the protocols need to be written, so that you can do the best to prove that your procedure is safe and effective. And that's really important. And finally, I would say that from the very beginning, Chris and we learned from Andreas Grunzig's legacy that we are focused on patient care as he was, but it's patient care that's always been backed up by a commitment to level 1 scientific evaluation of everything we did. And that's really the carotid stent story. And we've lost some battles, but we won the war.
We won the war.
Won the war. Lost a few battles. That's great. Well, I want to thank both of you for your insights. So I learned a lot. It was great. And on a personal level, you two have been just absolute giants in the field. And for a person of my generation looking at you, trying to understand the importance of the clinical science and the sacrifices that you made to make this happen is just without equal. Thank you so much.